Good morning, all of you. Welcome to the CPD webinar series organized by Society for Health Research and Innovation. First, I would like to introduce you with the housekeeping rules. The webinar link will be available from 9 a.m. to 9:45 a.m. to join in. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points. And the CPD points are strictly adhered to the NCCPD guidelines. And you will receive a certificate once you fill the Google form at the end of the webinar. Kindly use the format of initials followed by surname without any prefixes. Thank you for the strict adherence to the CPD regulations and your kind compliance. So today's topic is imaging in the acute stroke. The guest speaker of today's webinar is Dr. Amila Chandrakumara, Acting Consultant Neuroradiologist at the National Hospital of Sri Lanka. He was the Clinical Fellow in Neuroradiology at Manchester Royal Infirmary, Manchester University, UK. Over to you, sir.
Thank you very much for your kind introduction and good morning to everyone. I am Dr. Amila Chandrakumara and I would like to thank the Society for Health Research and Innovation for giving me this opportunity to present in this timely topic. So thank you all for the support and the invitation. And so today's topic selected was imaging an acute stroke. So we all know the acute stroke is an emergency, and stroke is a syndrome caused by disruption of blood flow to part of the brain due to disruption of the blood flow to part of the brain due to either occlusion of a blood vessel, which is the main cause, and we call it ischemic stroke, and it happens in about 80% of cases, or could be due to a rupture of a blood vessel, resulting in injury to cells and causing sudden loss of focal brain functions. So the main thing we have to remember is time is brain. So every second we spend on a patient after a stroke is a loss of neurons, which are irreversibly damaged. So we should act fast, and everything related to management should be done quite fast to stop the brain cells getting damaged to preserve brain functions. So we have goals in imaging in neuroradiology. The main, we image the patients in acute stroke to help the answer these questions. The questions are to diagnose, the prognostic the patient, and select the treatment options. So in diagnosis, does the patient have a stroke or not? Is the stroke ischemic or hemorrhagic, which is the main thing to be determined, because management could be very different in context of whether it is ischemic infarct or hemorrhagic infarct. The prognosis. What is the size of a stroke? Is the stroke already too big? The patient is likely to have poor prognosis. And the other thing is treatment selection. Would this patient with a ischemic stroke benefit from thrombolysis, endovascular treatment, or combination of both? What is the risk of bleeding with thrombolysis? So you need to answer these questions, help physician to make treatment decisions. The CT and MRI are the two main imaging modalities used in acute stroke. The imaging, although the MRI is considered a more sophisticated imaging tool than CT, and CT is the workhorse because there is almost universal use of CT in everywhere, kind of. And acute strokes are the speed and ease of acquisition, because in MRI, it takes time to acquire images compared to CT. And usually MRIs are available in a certain time period, and but CTs are available 24/7, and there are less contraindications to CT than MRI. As you already know, MRI uses very high field magnets, and these magnets can interfere with the patient's some of the life-saving devices, or patient may have had a previous trauma. We don't know the patient history when the patient is coming to the hospital. So with these contraindications, CT is the main modality of choice in imaging, just because it's too fast available and there are lesser contraindications compared to MRI. So in CT modalities, we use non-contrast CT, CT angiography, and CT perfusion to answer all these questions. So first, which modality? I already said CT or MRI. So because we use the CT more often than MRI for the stroke evaluation, because it's available and it's less time consuming. As I said, time is brain. So we need to do imaging very fast. And also the lesser contraindications compared to CT. And so CT we use more. These are the kind of pros and cons of CT and MRIs. Kind of, you can see there are pros for MRIs, certain cons for MRI. The major the thing in MRI is the time constraint and the history of the patient might have the blast injury via metal, the metallic things, kind of metallic foreign bodies within the body. So we don't know when patient comes, but and the patient is these are acutely ill patients with a lot of life-saving kind of instruments and devices all around the patient. And if you've seen an MRI scanner, its bow is very long. So the patient should be going to the machine. So these practicality problems compared to CT, where the image can be acquired in a half a second, where the patient cooperation also not that important compared to MRI, where patient has to kind of sit on the machine for more than 10 minutes basically to acquire image series in MR imaging. But whereas CT, you can acquire images in a split of a second in the brain. Only disadvantage is the radiation, but you know, most of the patients are elderly, so radiation is not very significant one with the small area image. And as I already note, the CT techniques we use are non-contrast CT, CT perfusion, and CT angiography. So these are the things we answer. As I said previously, is this stroke ischemic or hemorrhagic? We answer it with the non-enhanced CT. And is there a flow obstruction of a major vessel? Then we do CT angiography and evaluate that one. And which tissue is already infarcted, which is still salvageable? We answer that question with perfusion CT and also with perfusion CT angiography. So treatment decisions in acute stroke made after carefully considering the clinical information and assessing availability of imaging. As the time is a major constraint, the management of patients with acute stroke, the clinical assessment and imaging interpretation must happen really quickly. So balancing the need for a rigor evaluation of these patients while saving the time, recognize the need for speed evaluations, and there's a trade-off. So many physicians kind of try to difficult to make. However, to achieve optimal outcomes of patients, so these physicians must be able to seek and acutely receive the clinical and imaging information that is absolutely essential in making treatment decisions. So everything should be prepared when patient arrives to the CT suite. So we make everything arranged when the patient arrives, and the examination should be ideally be completed and analyzed in 15 minutes in real clinical setting using the CT scanners, which are newer, because these scanners acquire images really fast. Like in a half a second, you can acquire image of a brain. So because of that, the movement artifacts, and I will get them later, these things will be very low and give a clear image of the patient. And perfusion CT and CT angiography are done only if hemorrhage has been ruled out with a non-enhanced CT. So that's the most important part, to check the non-enhanced CT, exclude hemorrhage, and then go into the pathway of the patient. So non-contrast CT. Non-contrast CT must perform and report as soon as possible. The key role of non-enhanced CT, as I said earlier, is to exclude or detection of hemorrhages. It is also useful to see other possible mimics of stroke mimics we call. For example, the neoplasm, the arteriovenous malformation that could otherwise be very difficult to diagnose clinically and produce a clinical neurological deficit. And the key role of the images first to be analyzed with we usually analyze images. Uh, as a radiologist, we use windowing. So in our eye, it's a grayscale image, as you already know. The CT image is a grayscale image. So to our eye, only 50 kind of close to 50 shades of gray are visible. So we need to get the all densities in this 50 range. So we narrow the windows to see a particular uh, tissue. In a brain window, we use to see the brain, and in a bone window, we narrow the window to see the details of the bone, but not the details of the brain. So it is so we look at the image in the brain window, and then if you suspect stroke, we should do the stroke windowing. And stroke windowing is usually 40. You don't know, we don't know the detail, but we narrow down the window, and it will increase the the contrast between the abnormalities, and demonstrate subtle abnormalities such as ischemia very clearly. And ultimately, there may be ischemic sign established. So if you not diagnose it at that time, so it will develop the signs of an infarction. So this is yeah, this image shows the importance of windowing. So if you look at this is a normal brain window, and it's at a glance it looks normal, but if you are really kind of careful, you will see there is this area. If you look at this area, the gray white matter interface, it's not that clear in here. And if you narrow down the window, it's very clear there is gray matter and there's a white matter. There's very sharp demarcation between gray and white matters. But this area, look at this, you can see even the gray matter. So it's all dark. So this is an early sign of stroke, acute stroke. So this should be diagnosed, and should send the patient for a stroke pathway. And this is the, as I said, this is effect of motion. And in this image, is both are same patients with a movement artifact. So you can appreciate the gray white matter or any anatomical detail. And so in this is the patient kind of cooperating the scanner, and you can see the basal ganglia, the lentiform nucleus on right side, but you can't see much detail on the left side where there's a very low density the involving the basal ganglia, like lentiform nucleus in this side. So this is the infarct involving in one regions. So you can see the importance of motion, where patient should be kind of stable. So this is why the CT is important, because if the patient kind of can't stay in a can't stay like straight in MRI scanners, it's very difficult to interpret images. But CT, because you can acquire images in a kind of less than a minute, less than a second, so it's very detail will be very high. So when we uh, kind of presented with images, what we see is the non-contrast CT is the first thing obtained, and we assess we have a kind of structural way of assessing. It's called a rapid assessment of a non-contrast CT in acute. So because we can't go into detail the other abnormalities like sinuses kind of thing. The important thing is here the whether it is an infarct is there or is it a hemorrhage, to exclude hemorrhage. So for this, we have a telltale early features of stroke. These are the early features. So we will exclude the hemorrhage. Then we actually look for the eye deviation. If there's a large infarct in one side, the patient's eyes tend to have a deviate to that side. And so it's not a kind of, but it's an observation we made. And there's a thing called hyperdense artery sign. I will show you in detail the next few slides. There is also the early ischemic changes like obstruction of the lentiform nucleus, as you've seen the previous image. And there's another one called loss of insular ribbon sign and loss of gray-white matter differentiation of surface cortex, as I said, shown you previously. And we also calculate the aspects. So so this one also have, if you can look at closely, there is the insular ribbon can be seen quite nicely in this side. but you can't appreciate this side. So this is a loss of insular ribbon side. And so a word about aspects. So aspects stands for Alberta Stroke Program Early CT Scope. It's a 10-point ordinal scale that measures parenchymal hyperattenuation or loss of gray-white matter differentiation in the brain territory supplied by MCA artery. So this is basically, we look at the MCA artery, which is the most common artery involved with strokes, and is assessed on axial non-contrast CT. So we usually get two sections, one at a level of basal ganglia and one above the level of basal ganglia, and we call it ganglionic and supraganglionic levels. So, and at these levels, we take 10 areas and we give each, I will show you on the next slide. We give 1 mark for each area. And if the area is involved, we deduct 1 mark from that area. So depending on the marks, you have the score of 0 to 10. And so I will show you it in here. So these are the areas, sorry. These are the areas. And this is the ganglionic level, and this is supraganglionic level. So at ganglionic level, you have C caudate nucleus. So that's one mark there. And L for lentiform nucleus, 1 mark there. Internal capsule, IC. So 1 mark goes to there. And at the ganglionic level, you have M1, 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 M2, and M3 levels. So this is a quite simple thing. And so we give 1, 1, 1 each, and total mark 6 there, and there 7 there. And then you kind of the supraganglionic levels, another 3 marks for M1, M2, M4, M5, and M6 territories. So M4 is anterior MCA territory, M5 is lateral MCA territory, and M6 is posterior MCA territory. So we will assess the image and count how many marks can be deducted from these areas. If there is abnormality or loss of gray white matter demarcation in the internal capsules, we deduct 1, so it's 0. And if the lentiform nucleus is abnormal, again 0. If internal capsule is involved, then it's again 0. Insular cortex is normal, we give 1. M1, M3, and M4 territory is normal, we give each 1, and so on and so forth. And we calculate we get the total and calculate the number. So here we used to get the numbers 6 as equal or more than 6 as the indication to go ahead and do the thrombectomy or manage the next levels of imaging. So you can do it practically. So this is a image. I will scroll down, try to appreciate the changes while I'm scrolling up, sorry, and try to appreciate changes, whether you can see the changes I have already told for you. I'm doing a bit fast, so it's vertex. So going down. Okay, first thing I notice here is the eye deviation. You can see patient is looking at the right side. And if I kind of move forward, there is this image. So you can see the very dense middle cerebral artery. This is an uncontrast study. And this middle cerebral artery on the other side is not that dense compared to this side. So this is called the dense MCA sign. And this is a feature of acute stroke, hyperacute stroke, sorry. And you can see the insula very nice here, insular ribbon, quite nice. But in this side, you can't see the details. The gray white matter differentiation is not there. So this is loss of insular ribbon sign. And if you go a bit further, okay, here you can see the basal ganglia, the caudate head, both sides looks normal. But if you look at the lentiform nucleus, the detail of the lentiform nucleus is not very clear on the right side compared to left side, and rest of the brain shows very like this area, The gray-white matter is very differentiated, but here you can't even see a gray matter, white matter, and there's a very swelling. And you can see, if you look at the very detail, you can see the sulci very nicely. Here, the sulci are quite effaced because of edema. And the changes are extending into the vertex, so you can see gray-white matter nicely there. There you can see details. So this is an extensive middle cerebral artery infarct. So probably score would be quite low. And so hope you can appreciate that one. So other modalities we use, if you kind of exclude it, then patient goes to CT angiography. And these things should be done very fast, you know. You have to look at the non-contrast CT at the same time. Then if there's no hemorrhage, patient then and there go ahead and do the, and aspects is all right, patient go and get down the CT angiography. So CT angiography is an essential tool in the management of patient with acute ischemic strokes. And since the acute stroke is a vascular disease, and imaging the blood vessels helps to determine the etiology. The main role of CT angiography is to reveal the status of large cervical and intracranial arteries and thereby help to determine the occlusion site. Also to depict arterial dissection, grade chlorlateral blood flow, and characterize the atherosclerotic disease. So CT angiography detects thrombi within arteries and their extent, collateral status beyond occlusal thrombus, and other associated pathologies. So it's best to acquire CT head and neck angiogram from aortic arch of the vertex to visualize all the extracranial and intracranial arteries supplying the brain, and it takes only few minutes to do head and neck CT angiography immediately after an uncontrast CT. So it is best to acquire the head and neck CT angiography to visualize, again, I'm emphasizing it, to visualize extracranial arteries and intracranial arteries supplying the brain. Because it's important tool, because we can plan in acute endovascular thrombectomy. So assessment of aortic arch, are there any anatomical variations? And because of this anatomical variation, this helps in choosing the type of catheter to be used and the pathway to be used, and planning the procedure is quite easy with the available images. And location and extent of thrombus within the arterial tree also helps to determine the device type and profile used for mechanical thrombectomy, and also determine the risk of recurrent strokes and planning acute endovascular treatment. So okay, this is imaging features on CT angiography too. So this is what we can, again, simply, we can't go into detail and look at everything in the imaging set. Rather, we assessed, very rapid assess the patient to see the following there. So abnormal looking vessels, we look the presence and location of the thrombus, whether it's intracranial, extracranial, and we look at the collateral status and any large artery pathology like plaque or dissection, then aortic diseases. So other pathologies like carotid webs, vasculopathy, and arch and large vessel anatomy, we look in these angiography images. So this image shows quite clearly, you can see there is this maximum intelligent projection image, axial section with thicker slices, and see the non-filling segment of the middle cerebral artery in one segment. And this is a thrombus, and you can see, but distal circulation is rather maintained. And here there is the carotid web, basically. It's occluding the internal carotid artery at the level of the carotid bulb. So these things we look, and so this is image. These are angiogram images of a 59-year-old man with hemiparesis. He has had an arteriotraffic accident just before the complaining of hemiparesis, and see the images from aortic ascending aorta to the brain. And ascending aorta, you can see the filling of the aorta with contrast, and on top of that, you see a flap extending from ascending aorta to the aortic arch, into the descending aorta, and also into the common carotid arteries. So this is a dissection. This is a dissection flap extending aortic dissection, probably type 1, type A dissection, extending into the carotid arteries. completely occluding the vessel distally. You can see normal carotid artery on the left side, but right side, there's no carotid artery. But intracranially, there's some maintenance of the flow. You can see the right MC artery, but distal circulation is compromised. You can see here there are a lot of blood, a lot of vessels, the MC territory, but here you can't see vessels, resulting in ischemia of the right middle circulatory territory. So if you look carefully, you will see the findings I already told are there, everything will there. Effacement of the sulcite, the loss of gray white matter, everything. This is a large MC stroke due to the dissection flap causing complete occlusion of the right common carotid artery. Next, so collateral status. These imaging modalities are not done quite frequently. Like it's called a multi-phase CT angiography. This is an excellent tool to assess collateral status. And so what we do here is we acquire kind of 3 sets of images and in multi-phase CT and while giving contrast, and we see how contrast kind of go into filling of the vessels in the brain. And usually we assess the middle cerebral artery level. And this is what, so we have 3 images we acquire and areas of ischemic brain with minimal or no vessel indicative severe ischemia, resulting in irreversible injured brain, an ischemic brain with 1 phase delay in contrast filling with impaired washout of that contrast in the 3rd phase, indicative of a severe ischemic brain that can be saved with quick reperfusion. The other thing is ischemic brain with 1 phase delay in contrast filling with washout of contrast in 3rd phase, indicative of mildly ischemic brain. So this will simplify this one, simplify that one. So this is a normal side. The red side is the abnormal side, and you can see filling, but there's delayed filling of in the left side, and but it washed out kind of normally. There's only delay. There's a delay, but enhances and washed out. So this is mildly ischemic brain. So if you go into the next brain, you can see the area shows filling, but not as much as the right side, but it stays. There's no wash off of contrast from the arteries. So that suggests severe ischemic brain, which can be saved with quick reperfusion. And the other thing is it doesn't enhance, so it's very delayed and never enhances, so it's irreversibly damaged brain. So this is not we. And the next thing is, and here is another representation. You can see middle cerebral artery levels, M4, M5, and M6 levels, and you can see the brain on right side looks normal. This is normal perfusion. Phase 2, phase 3 washed off. But if you get the M6 region, this region, there's a minimal vessels seen in the arterial phase, right? And it's not filling. So this is like the last image of the previous slide, and this is kind of irreversible ischemia. This is non-salvageable. If you look at the M5 region, there's a bit of a delay, but it stays, right? And this is called salvageable with reperfusion. And the other image is mildly perfused, where there is a mild delay in washout. So it's a mild ischemia. This area is mild ischemic. This is salvageable because it persists. And here no enhancement whatsoever, so it's irreversibly damaged. So before going to the next slides, I would like to emphasize ischemic penumbra. Ischemic penumbra is a concept. With the ischemic area, there are 3 major zones: core, penumbra, and benign oligemia, and also the normal brain. Ischemic penumbra denotes the part of an acute ischemic stroke that is at risk of progression to infarction, but still salvageable if reperfused. So next image, I will show you the concept quite clearly. So Ischemic core is number 4, representing the tissue compartment that is irreversible damage or infarct, which is surrounded by the to various extent by ischemic penumbra. Right, number 3 is ischemic penumbra, and this area is at risk of going into the ischemic core if not treated, and it's potentially salvageable. And between the unaffected area, one is unaffected area, and the ischemic penumbra, you have a area of kind of reversible oligemia. So this area, the number 2, whether you treated or not, this is going to survive. Number 2. So the each time spent on a patient without treatment will cause the ischemic core to increase in size up to the penumbra. So our imaging modalities we use to image are called penumbra imaging, where we assess the amount of salvageable brain tissue, and then if there's a significant amount of salvageable brain tissue, we should intervene and treat these patients. Whether they are these are important in kind of situations like wake up strokes, where the stroke time window is not very clear. So penumbra imaging is used in such situations to direct patients to treatment pathway. So assess to detect the penumbra, we most often use imaging modalities CT perfusion. Like multi-phase CT angiography, this technique also uses multiple scans in a series of time, and the computer then analyze the flow and the formulas uh, produce us with maps of cerebral blood flow, blood volume, and MTT. And there's other parameters like time to peak and Tmax, but most often we use cerebral blood flow, cerebral blood volume, and MTT values. In acute stroke, there is a central, as I told earlier, this is for the penumbra, so we made the penumbra. I will let you know next slides. The cells in penumbra potential is salvageable with early recanalization, and CT perfusion may be used in acute stroke to predict ischemic infarct and salvageable brain, also to predict the risk of intracerebral hemorrhage after acute stroke treatment. Intravenous thrombolytic therapy can be benefit, so we like to find the perfusion mismatch. And CT perfusion. So as I said earlier, the imaging generates data of cerebral blood flow, blood volume, and transit time within the brain tissue. So we overlap these images in an anatomical image and make interpretations. So main challenge is motion artifacts, and also there should be a timing, the start of imaging and the giving the contrast. And color coded perfusion maps show cerebral blood volume, mean transit time, and cerebral flow. This generated by the computer, and the quantification of these parameters is based on central volume principle. Cerebral blood flow equal to cerebral blood volume divided by MTT. So the MTT map is analyzed first. I will show you in a subsequent images because it shows the most prominent regional abnormality. So first we detect the abnormality and we see whether it's penumbra or it's infarcted core, depending on the chart here. You can see if it is an infarct core, MTT is elevated. So cerebral blood flow will be markedly decreased. And same thing happen in penumbra, where there is elevated MTT and decreased cerebral blood flow. So MTT will be reduced, but if you look at the CBV map, you will see there is normal or mildly increased cerebral blood volume in comparison to the infarct core, which shows markedly decreased cerebral blood volume values. So in this, with the help of this, we can detect this one, penumbra. So this is MTT. So this is the intensity of the signal. So that means if the transit time is increased, it will be higher values. That means red equals to red. And if it is very low, transit is high or fast, it will be darker value. So you can see the higher values there involved in the middle cerebral artery territory. It's a quite large area. And you can see the same thing. You can see the cerebral blood flow. You can see the unaffected side cerebral blood flow values. And this is the value of cerebral blood flow, which is slightly reduced. But you can see what happens to cerebral blood volume compared to other side. It's quite high and close to normal or slightly higher. So this is a penumbra. You can see how we interpret the images. And in a ischemic core, what happens is you can see very high MTT and low cerebral blood flow and low cerebral blood volume. So if it is a penumbra, this should be either equal or higher than the flow volume on this side. But this is ischemic core. This is kind of already damaged brain. So this is a small case for you to understand concept more clearly. This is an uncontrast CT. When you evaluate the patient, he had this abnormality here in the internal capsule. There's very low density. So we go ahead and do the angiogram. Angiogram detects the non-visualization or the non-filling of the in one segment of the right middle cerebral artery, but with some distal perfusion, distal vessels, and then go ahead and do the CT perfusion studies. So this is MTT, mean transit time. See a large area of prolonged transit time. And then cerebral blood flow values. You can see flow values are kind of very reduced in the kind of acute infarct we see in the CT area and as adjacent area, but larger area, it looks kind of low. And blood volume, again, so it's reduced in this side, but in the other areas, it looks more than the other areas. So if you look at these images, fuse, you can say this area is already infarcted. This is co-infarction, and the rest is penumbra. And we can kind of overlap these images to an anatomical image to have a better idea. So this shows the imaging, and then shows the core of infarct with a penumbra. And this is the post thrombolysis, where the patient kind of the core is anyway infarcted, so it's not recovered, but the penumbra salvaged from getting into the large infarct. So this is what we're going to achieve. The penumbra is going to be salvaged by treating these patients with thrombolysis. So important points to remember are in patients with poor cardiac output, atrial fibrillation, severe proximal artery stenosis or decreased blood flow can lead to inaccurate perfusion maps. Other one is there may be some ghost infarct cause because sometimes it will show areas that will not show infarct on parallel up images. This exclude a large volume of brain. So this, as I said earlier, this we evaluate mainly the middle cerebral artery territory, and the posterior fossa and superior cerebral hemispheres are kind of ignored. Small infarcts are poorly visualized on perfusion maps due to their low resolution. In case of seizures, ictal region shows hyperperfusion, which may lead to interpretation of hypoperfusion in the frontotemporal hemisphere, mimicking an infarct. So that's why we should initially evaluate the non-contrast images, then go into the step up from angiogram, then to the perfusion images. So this is what we do, predicting risk of intracerebral hemorrhage after acute stroke treatment. Brain tissue with very low blood flow on CT perfusion is likely to infarct early. By detecting regions of very low blood flow or blood volume or regions of brain with increased blood-brain barrier permeability, CT perfusion can help to predict brain regions with increased risk of hemorrhage after acute stroke treatment. So if the already infarcted infarct core is very large, and the penumbra volume is kind of less than kind of 70 or 80, then there's higher risk of hemorrhage. And subacute appear in changes on uncontrast CT or regions of the brain with changes seen in diffusion weighted imaging and fluid attenuation immersion recovery images may also help the clinician to predict the risk of hemorrhage with acute treatment. I will show this in the next few slides. So this is the other important thing. As I said earlier, the goal is to assess imaging to determine the type of stroke. So assess markers of prognosis and treatment risks such as the extent and severity of ischemia or hemorrhage. Identify treatment targets such as presence of large vessel occlusion in ischemic stroke or the spot signs in patient with hemorrhage and make decisions. So this is very simplified version. So patient has come up to the CT perfusion kind of the segment, and then we evaluate whether it's MTT high, CDF normal, and CDV normal, treatment indicated, because this shows there's a penumbra. And if the MTT transit time is high, CBF decreased, and CDV normal, again, this is kind of penumbra, but treatment may be given because CDV is normal. And there's other possibilities, MTT plus, CBV decreased, CBF decreased, and CBV decreased. Then this is already infarcted. This suggests it is an infarcted core, and the treating this could induce hemorrhage, and risks are more. So that's why the treatment might be harmful. This is an oversimplified version, but this is in a nutshell. This is what we do. So MRI, we frequently don't use MRI, as I said previously, in acute stroke setting because it's time consuming. Because every time you spend excessive time you spend on a scanner is the patient is devoid of vision, is losing neurons. So, but MRI is very kind of specific in detecting strokes. And so just minute after stroke onset, cytotoxic edema characterized by restriction of water movement develops in infarct tissue. This is visualized as decrease in ADC and high signal on diffusion. An important concept is diffusion flare mismatch. Actually, we use this one, and even though it is not well evaluated, so this is what we do, and we acquire images of flare, diffusion, and ADC, and we look for a mismatch. So if you look, you can see an infarct here, it's ADC low and diffusion high, and there is abnormality in the flare. So this is matched defect. So this matched defect means it's already infarcted, and no point of treating because it's a core. So other thing is mismatch. We look for a mismatch like this. So you can see diffusion restriction involving the region of the basal ganglia, and there's no subsequent flare abnormality. So this is a mismatch, and this kind of suggests it's not already kind of infarcted and ischemia, and it warrants treatment. So it's not extensively evaluated, but it's unusually quick to perform. No contrast is administered, no exclusion of hemorrhage. But you can add SWI images to this one, but only make this, it takes a bit of time to exclude hemorrhage, but uncontrast CT will exclude hemorrhage then and there. So as well as CT, MR also can be used to do the perfusion studies. The thing is, the MR perfusion studies can be either contrast enhanced or non-contrast. So we can do without administering contrast the perfusion studies in MRI scanner. And so here, if you give contrast, it's a gadolinium base, but you don't always have to give contrast. And so these are the imaging sequences we acquire. What we look for is diffusion, perfusion mismatch. We usually kind of do these studies for the patients with kind of wake-up strokes where we are not sure the patient, the actual time, and look whether it's worth going and thrombolize these patients. And perfusion weighted imaging is a term used to denote variety of MRI techniques able to give insight into the perfusion of tissues by the blood. So there are dynamic susceptibility contrast MR perfusion, and there's a dynamic contrast enhanced MR perfusion study, and there's an ASA. which is kind of a good study to see the abnormalities without giving contrast. And so this image shows the diffusion weighted image, the abnormality here. And we similar way to the CT, it acquires the images in a kind of the timely manner and produce a perfusion map, and it will show the lack of perfusion area in the image, and you can see the perfusion as a mismatch. So this is core, and this is the penumbra. So that's why these are called penumbra imaging. So it will depict the penumbra quite clearly, and this is shows no mismatch. Kind of this is the ischemic area, and this shows the the, the stroke kind of perfusion defect similar to the diffusion defect. So this is a match defect where the whole thing is already infarcted. And the DSA. DSA is it's not diagnostic. Basically, we after diagnosing everything, this is done just before the intervention, where mechanical uh, thrombectomy is done. So here, sorry, um, before mechanical thrombectomy is done. So here there's cutoff of the middle cerebral artery, and after the intervention, it has improved the circulation and restore the perfusion. So this is the target basically, and so we come to the section where we diagnose the MCA occlusion and large penumbra. Then we go on, do the DSA, confirm the finding, and then do the mechanical thrombectomy. There are a lot of ways of doing mechanical thrombectomy, and so we remove the thrombus, and you can see the distal circulation is starting to appear. So this is a target. And so in conclusion, the time is the essence when making decisions, treating patients with acute stroke. CT is frequently used as a primary imaging tool in these patients due to availability and speed, and also lesser contraindications. And non-contrast head CT and CT angiography of the head and neck are essential modalities in patients with acute stroke, helping to diagnose stroke, determine prognosis, and identify patients who might benefit from acute stroke treatment. Techniques such as multi-phase CT angiography, CT perfusion provide additional assistance in identifying salvageable brain and assessing the risk of treatment. So key points I would want you to remember is the key role of non-enhanced CT is the detection of hemorrhage or other possibilities like tumor mimics, like stroke mimics, and such as neoplasms and AV malformations that could cause the neurological deficit. The cells in penumbra are potentially salvageable with early recanalization. The main role in CT angiography is to reveal the status of large cervical and intracranial arteries and thereby help define the occlusion site, depict arterial dissection, and grade collateral blood flow and characterize the atherosclerotic disease. Just remember, time is brain. So we should not kind of spend a lot of time in these patients. The door to needle time should be very low, should keep it very down, and door to scanner and in the scanner times should be very low. And it is important to kind of remember this one. If you see a stroke patient, ischemic stroke patient, time is brain, you have to act fast. And I will conclude my lecture at that point. And if you want, I have few questions. I don't know whether you will be able to answer these. So, any questions before going to the?
Thank you for the informative lecture, sir. There are few questions we have received in the pre-survey. You have answered most of them. Shall I share the screen, sir?
Yeah, please.
These are the questions we have received in our pre-survey, sir.
Yeah. So, differentiate SOL and infarction. So, as I said earlier, in acute stroke, the infarction has certain features. I told you it has this the signs, the gray white matter differentiation abnormalities. So, if it is a SOL, the main thing in SOL is there will be a mass effect. There will be a perlesional edema. There will be the tissue expansion, which is not seen in acute strokes. If the strokes becomes quite late stages, established infarct may produce a lot of mass effect, which mimic stroke, but at that point, patient kind of pathway is going to be different, and he might need an MRI, but careful evaluation of the CT with findings, and also with the help of contrast, we can exclude SOL from an infarction. In initial stages, it's just looking at the images. SOL is quite different to hyperacute infarct. So imaging in delayed presentation is beneficial. So delayed, that's why I told you, yes, it benefits, especially if the patient is wake-up strokes. So we have to do perfusion imaging to evaluate the penumbra. And if the penumbra is large enough and its core is small enough, we will go ahead and do the treatment. Anyway, we have the patient need treated because he will benefited from the treatment. But delayed presentation, I thought mean like that if it is kind of possibly going days after and it's an established infarct on the CT and the aspect score is more than less than 6, which is our cutoff value, and there's no point of because the harm is more than the good the patient is having. But anyway, patient has to be imaged because you need to have diagnosis and need to exclude anyway mimics. So yes, it's beneficial. Indication for repeat CT in stroke patients when to repeat. Yeah. So usually repeat CT is done after 24 hours. But if patient develops, while patient on the treatment, if patient develops kind of features of hemorrhage, it's a headache and new focal neurological deficit, at that time, patient should be imaged immediately with an uncontrast CT. So otherwise, if it is plain and simple stroke, after 24 hours. Do we have to do CT brain in all cases of TIA? I think if you diagnose TIA, I think yes, you have to image and have to do the carotids, I think carotid arteries, and to check. So I cut off some of the slides of my presentation because of time constraint, where you can evaluate the carotids and to check the carotids, the ultrasound, the Doppler scan, and there are certain things we'll assess. We assess the intimal medial thickness and the plaques. Those things you should assess in TIAs, as you already know. I think all cases, I think, yes, you have to do. There are no hard and fast guidelines imaging TIAs, but base thing is, the thing is whether there is a primary source of shooting emboli, and if emboli source is there, there is treatment. So that's why we have to image. Not only the CT brain, I showed you its carotids. We have to do. And any preparations before imaging? No, these are emergencies. No preparations, no investigations, nothing. So, so these patients I should emphasize when you are doing these are kind of sometimes come as questions, but when emergency situations, the patient's life is in danger, there's very low kind of data studies shown that the anaphylaxis and renal impairment things where you have a high serum creatinine level. So when patient arrives, the department, we don't check anything in these situations. We just go ahead and do the protocol because the studies suggest the kind of contrast-induced nephropathies and allergies are quite rare. But if that happens in these acute settings, people would have be able to manage it, isn't it? Anyway, the contrast-induced nephropathy is quite uncommon thing. So no, we don't need any preparations. We don't ask for any preparations in acute emergency settings or stroke. So last thing is, if imaging is not available within the window for the treatment, what would be the management? So, uh, so these patients, I think I'm not the one should answer this question. It's a neurologist are the ones who managing these patients after kind of thrombolysis. And anyway, patient is kind of going in this pathway uh, up to the point where we decide not to thrombolize, and then the management is with the neurologist uh, who will kind of do the management. Anyway, I would like to give you a small thing about posterior circulation infarcts. Posterior circulation infarcts are another kind of dubious thing where there's no available data to kind of give exact management, but there's a research says the basilar artery occlusions and tip of the basilar syndromes are very kind of they are kind of beneficial of thrombectomy, especially the basilar artery thrombus. You can do mechanical thrombectomy for basilar artery thrombosis, and also there is if there's established infarct, sometimes you have to do the craniotomies and to answer the previous question. If the patient kind of old and if it's a large infarct, later they will develop cerebral edema at the area, and then there is a risk of mass effect and causing herniation of the brain. So at that point, there is a we should intervene and do the either craniotomy, especially the posterior fossa thing. You have to do the posterior fossa craniotomies to decompress the cerebellum. And there are some minor stroke syndromes like arterial percheron, which is managed kind of same the way as this, as I told. The only difference is posterior fossa, where CT won't show anything because posterior fossa is not that good area to kind of visualize on uncontrast CT. And the patients usually present with vertigo, not like typical face arm, your typical presentation, and the presentation is different. But if you diagnose the stroke, there is management kind of same. They will benefit from thrombolysis, and but there's no data. That's the thing, and definitely there's a thrombectomy for like basilar arteries, and so pathway would be going to be the same. Any other questions?
So there's another question in the chat. Where is DSA available?
Sorry, I didn't get it. Where is
DSA available?
So DSA is digital subtraction angiography, which is an invasive thing, and you insert for the brain. We usually use the femoral axis, and we catheterize one of the femoral arteries, and we insert long catheters through the guide wire and go to the brain, neck vessels, and do the DSA. DSA is available in, I think, every teaching hospital. Colombo, there are 3 places like neuro trauma, the main X-ray department, and epilepsy unit. There are DSA is available, and I think Candy is available. Ragam is available with the neuroradiologist. The interventional radiologists are the ones who are doing that, and the Karapiti it's available, Badulla it's available. I think there are a lot of available. Is there for DSA, and you just have to ask from your radiology department. They will definitely assist you in kind of if the patient need DSA, they will definitely arrange a place where it is available. I have few questions if you like, but time is not there. No? Yeah. So any more questions?
No, so that's all.
Hi, thank you very much. Thanks for giving this opportunity. Yeah.
Okay, so thank you very much for your excellent lecture and precious time. It was very informative lecture. So for the participants, you can fill the link in the chat box. And in the absence of further questions, let's conclude today's session. Thank you again, sir.
Thank you very much.